Good evening, all from IMA Kerala State Branch. This is yet another session of online webinar series of IMA Kerala State Branch. And today's topic is adult immunization, which is a less discussed topic. And for this, we have eminent faculty from Amrita Institute of Medical Sciences, Kochi. And to moderate this, we have yet another eminent person, Dr. Beena KV, who is the Senior Administrator of Amrita Institute of Kochi. Let me first welcome all the participants who have joined in the online platform to this webinar. And I take this opportunity to welcome our dear President of IMA Kerala State Branch, who is a great pillar of support for all the IMA AMS activities, Dr. Menon sir, to this function. Welcome, Menon sir. Our State Secretary, Dr. Roy, is here. Many senior leaders are here. I welcome all the senior IMA leaders, all the branch officials, and all others who have joined. I welcome IMA AMS Secretary, Dr. Vinodis Nair. Overall, let me welcome our dear speaker, Dr. Kiran, also to this webinar. Let me hand over my session to Dr. Menon to say a few words and inaugurate the session. Menon, sir, please.
Very good evening, Dr. Deepa, Dr. Vinod, all other senior leaders, delegates, and the faculty. It's good that AMS is doing a wonderful job arranging relevant seminars on pertinent topics very regularly. And adult immunization is one of the most important things which we have been debating this year also with regards to the health of the doctors and families. It is, in fact, many of us are neglecting these things. Those people with comorbidities, especially above the age of 65 also. Childhood vaccines usually decrease all the time, and the vaccination protects both individuals and, of course, with the herd immunity-like thing, the wider communities also benefited from these things. When more people are vaccinated, herd immunity reduces the spread of infections. And it also reduces the hospitalization rates, healthcare costs, disease outbreaks, and you understand all these things, I'm sure that. And anyway, today, in fact, we had an emergency meeting with the health minister, which was called last evening. So I was there. There's a high-power committee on the endemic, so it is epidemic, but or be endemic control. That was the topic for discussion. Various experts and DHS, Health Secretary, Additional Secretary, Public Health experts, then the KGM CTA, KGMI officials, all were there. We were discussing on these things. I stressed on the importance of sewage disposal, potable water, food safety, mosquito control. This should be ongoing process rather than we just jump on a sudden during the monsoon and start doing all these things. So that was my request I made to the authorities, that should be seen as an ongoing process so that we can have a better healthcare in the country. And similarly, the importance of vaccination also I have highlighted, because this flu, which is spreading like anything, the vaccines can prevent, especially in the, as I said, immunocompromised people and others. Similarly, the importance of pneumococcal vaccine. In fact, I was happy to learn that the secretary, the in charge, who is in charge now, Dr. Sharmila, and she was telling that they have already initiated actions regarding the vaccines, maybe flu vaccine or pneumococcal, I don't know. That is the impression I got. So generally, things are going in the right direction with the new ministry also, I think. And they have told us also, and I could echo there. And I have also highlighted that IMA, being a body with a large membership and a network of the state, will be able to help the other government on these grounds, conducting awareness classes, for doctors and training for doctors and awareness class for the public, then running fever clinics, then coordinating the activities at district and state level. So we'll come out with some plans very soon, within a few days' time. I just want to tell you that because I just came from that place and just entered the home. My house, I just entered. So on that note, I declare that this webinar is inaugurated, and I'm sure that it will be a very enlightening session for every one of us. All the best. Thank you, Deepa, and carry on.
Thank you, sir. Let me first introduce the speaker before handing over to the moderator, Dr. Beena. Our speaker for the day is Dr. Kiranji Kulirankal, who is an associate professor in infectious diseases at Amrita Institute of Medical Sciences, Kochi, and he has immense experience in infectious diseases, HIV medicine, antimicrobial stewardship, infection prevention control, tropical medicine, adult immunization, travel medicine, and migrant health. And he was awarded the certificate of travel health by International Society of Travel Medicine, and he has done works in adult immunization, travel vaccination services, etc. I introduced Dr. Kiranji Kulirinkal to this session, and our moderator is Dr. Beena KV, who is an able administrator, a senior administrator of Amrita Institute of Medical Sciences, Kochi. She's also the mid-zone coordinator of IMA Kerala State Public Health Committee. And I hand over the session to Dr. Beena for moderation.
Thank you, Dr. Deepa. And am I audible?
Yes, ma'am.
Yeah.
Yes, ma'am.
Good evening, everyone, and Dr. Deepa and our respected State President, Dr. Menon, Dr. Vinod, and all the senior leaders in the Zoom platform, and Dr. Kiran and all others. If I start as an opening remark, I should say adult immunization is, we all know that many best treatment for any infectious disease is prevention. And the most powerful tool for the same is, of course, vaccination. And vaccination is often viewed as one of the greatest achievement in public health achievement, and responsible for preventing millions of deaths in the world. And while we know that especially Kerala state immunization programs have been highly successful, but adult immunization is an underutilized but critically important component of preventive healthcare. So selecting this topic itself is a good choice, Dr. Deepa and Dr. Vinod. And today we are witnessing, of course, the transitional change, the demographic pattern that is elderly people are come in more in numbers, and also epidemiological transition, because we are having not only communicable but non-communicable diseases also. Immunocompromised people are also on the rise. So vaccination, we should realize that is no longer a pediatric intervention, but it is a life course strategy. And today's discussion is particularly relevant for all of us, especially the practicing medical profession, because healthcare providers are the strongest influencer of the vaccine acceptance. So we are responsible. Our recommendations can significantly improve the vaccine uptake in the community, and thus bridge the gap between the evidence and, of course, practice. So I'm sure that this session, especially Dr. Kiran, we call him as the immunization man of Amrita, is an engaging session. And as we explore the evolving science, definitely the recommendations, the challenges in this, and the opportunities in adult immunization. Let us hear from Dr. Kiran. Over to Dr. Kiran.
I hope I'm audible and everybody can see my slides.
Yes. Yes,
sir.
Yeah, so I'd like to thank IMA for giving me this opportunity. So I'll jump straight into our topic, adult immunization. So I'll just give 2 seconds for everybody to have a look at the picture on the slide, and so it is basically the microscopic picture of variola major or smallpox. So if somebody asks you what is the greatest achievement that mankind has had, it is basically that we were able to eradicate a disease, smallpox, from the world. Let me just go to next week. So this all started by Sir Edward Jenner. He is considered the father of vaccination. So what he noticed was that women who were exposed to cowpox, that is a milder form, they were not getting smallpox. So what he did is he took the material from a blister of the smallpox from a milk lady, and then he injects it into his gardener's son, who is 8 years old, and the boy gets cowpox, and later Sir Edward Jenner exposes him to smallpox, and he notices that the kid does not get smallpox. So from there the idea starts, and in 1798 he brings out this first paper on vaccination, and vacca in Latin is actually cow. So that is how the journey started, and in 1980 we were able to eradicate smallpox from the surface of our planet. So now lately we've been seeing so many news reports where there is re-emergence of vaccine preventable diseases. You've got deaths in college hostels because of meningococcal meningitis, mumps outbreaks, measles outbreaks, and causing mortality. So that is the basic issue right now. So despite vast improvements in childhood vaccinations in India, adult vaccination coverage is negligible. And there's hardly any data on vaccine preventable diseases among adults from our country. There is no national immunization guidelines as such in India. The main vaccine preventable diseases are pneumococcal, diphtheria, tetanus, pertussis, polio, Hib, mumps, measles, rubella, varicella, rota, hepatitis B, hepatitis A, HPV, meningococcal, and influenza. Now, the immunization of an adult basically depends on the previous immunization received in his childhood. The major guidelines currently are made by the ACP Advisory Committee on Immunization by the CDC, the WHO, and recently the Association of Physicians of India had come out with an guideline for adult immunization. We'll be going into that. So why adults? So as in adults, as the age goes by, the immune system function deteriorates, and a process known as immunosenescence, in which both the genetic and environmental factors play a role. So there is impaired functionality of immune systems. The T cells replicative capacity comes down. The B cells, the total and naive B cells, there's clonal diversity. The efficacy of antibody response comes down. The NK cell, the chemokine productivity comes down. Phagocytic and chemotactic capacity of neutrophils come down. And there is inability of the ciliary lining, the microbiome diversity comes down, muscle mass formation comes down, cardiac wall strengths come down. So all these basically makes aging a disease-prone condition. And not just healthy eating and physical activity, even life course immunization is considered an important part of a healthy lifestyle. Another major important thing is that by 2036, around 27% of the total population of India will be more than 50 years. So we will have a huge population of adults above the age of 50. So the basic aim of us doctors is to make sure that this community is protected against vaccine preventable diseases. Now, there is this concept called life course immunization. So what it basically means is life course immunization is the concept of vaccinations providing protection and health benefits to people throughout their lives at different stages of their lives. So even though India has a very good childhood vaccination, that is not what is happening throughout the world. And like Sir had told, herd immunity plays a big part. If the population around us is protected, we are protected. So that is the importance of herd immunity. And as we spoke, as patients go, as age progresses, the immunity comes down, we are prone for more diseases. Then there is the high risk group. This is the most important population. Patients with chronic kidney disease, chronic liver disease, patients receiving immunosuppressant medications on steroids, patients with malignancies, they make up the high risk group. They have the maximum issues when a disease comes. The mortality, morbidity is all high in this high risk group. Then there are vaccinations which we should know because they can prevent cancers. HPV, vaccines against HPV is actually known to prevent cancers. So basic division of what are the types of vaccine. We've got live attenuated vaccines. We've got inactivated or dead vaccines. We've got subunit vaccines, the toxoid vaccine, conjugate vaccine, recombinant vaccine, and viral vector vaccines. And the most common inactivated vaccine that we have are the hepatitis A, influenza, rabies, and live attenuated vaccines. So this is one important thing that we have to know. Live vaccines have to be, whenever we give a live vaccine, there has to be a thought into it, because we cannot give it to immunocompromised patients and pregnancy, because we are actually giving a live vaccine. So chickenpox vaccine, the influenza vaccine, there is an influenza nasal live vaccine, the MMR, smallpox and yellow fever are examples of live attenuated vaccines. Then we've got subunit and polysaccharide and conjugate vaccine, the Hib, hepatitis B, HPV, pertussis, pneumococcal, shingles, etc. will come under that. Diphtheria and tetanus are toxoid vaccine. So what I'm going to do is I'm quickly going to go through all the recommended vaccines that we have to give in adults. So, and I will be giving the rates also, what is available at our center. So the rate might be lower or higher at your center according to that. So the first vaccine that we will discuss is varicella. As you all know, it is indicated in patients with no evidence of an immunity to varicella. So if somebody has already had a chickenpox in their life, then there is no need to give the varicella vaccination. It is a live vaccine. So any patients with HIV with a CD4 less than 200 shall not be given the vaccine. Immunocompromised patients should not be given the vaccine, and pregnancy also should not be given the varicella vaccine. It's a two-dose vaccine, and it is given 4 to 8 weeks apart, and it is given subcutaneously. So the Nexipox is a company that we have in our hospital. It's around 2,000 rupees. So another easy way to remember whether to give an IM or a subcutaneous vaccine, all killed vaccines are given IM, while all live vaccines are given subcutaneously. So varicella is a subcutaneous vaccine. We give the vaccine as it is a live vaccine. We give it as a subcutaneous shot. The next important vaccine is the zoster vaccine or the Shingrix vaccine. It is indicated in age 50 years or above, regardless of previous history of zoster. So even if the patient has had a zoster in the past, there is always a chance that the patient can get a recurrence of zoster. So this is indicated in patients who already had the disease. There is a Zostavax, which is a live vaccine, which we do not have in our current place. All immunocompromised patients have to be advised to take the Shingrix vaccine. It is a 2-dose vaccine separated by a 6 months duration. It is an IM injection, and we usually do not give it whether to patients who've had a serious allergic reaction to the first dose or in pregnancy. A major issue with this is the pricing of the vaccine. 1 dose of the vaccine is around 10,000 rupees. So 2 doses 6 months apart will roughly come around 20,000 rupees. It can be brought less, we have lots of vaccination drives and all. But if you ask a patient who's already had zoster, they will tell you, irrespective of the amount, they will take the vaccine because it is a very painful condition, and they will take the vaccine irrespective of the amount. Next is the typhoid vaccine. We usually give it to patients who go to endemic regions. So it is basically for travelers or persons who are in intimate exposure to a documented chronic carrier, and also patients or healthcare workers who work in labs with exposure to salmonella. There is the polysaccharide, there is the live oral vaccine, the capsule, and the conjugate vaccine. What we give in our center is the conjugate vaccine. It is necessary that all healthcare, all food handlers have to be given the typhoid vaccine. The next is the Hib vaccine. Anybody with a functional asplenia or a post-splenectomy patient is indicated to have a hip vaccine. Also, post-hematopoietic stem cell transplant, they are to receive the hip vaccine. It is available as an Infantrix hexa in our center, from which we separate it and we give the hip vaccine. It is a single dose and it is a kill vaccine given as an IM dose. Next one is the hepatitis A. Very, very important because we've been having lots of outbreaks in our state. So anybody traveling to endemic areas with hepatitis A, MSM, men who have sex with men, lab personnel with exposure to hepatitis A, or received or awaiting transplant. So we've got three types of hepatitis A vaccine. What we usually give in our center is the inactivated, the Havrix or the Havishur. It is 2 doses 6 months apart. It usually comes around 2,000 rupees. We have a Chinese BioVac, which is a live attenuated, but it is just a single dose. Then we used to have the combination, the hepatitis A plus the hepatitis B, which we do not have currently. So we currently give the inactivated vaccine, and we can give it for patients who are traveling to endemic areas and who are awaiting transplant. Next is the most important, hepatitis B, indicated in all healthcare workers, people at risk of sexual route of infection, people seeking STD, injection drug users, healthcare and public safety workers, household contacts, patients with chronic liver diseases, HIV, CLD, seeking protection from hepatitis B. So the basic regimen, what we all do is a 3-dose regimen in which you have a start dose, a dose after 1 month, then after 6 months. So we usually check the anti-HBs titers after the 3rd dose, after 2 to 3 months after the 3rd dose. So another major issue with the hepatitis B, you always get patients where there is an interruption of the regimen. So the thing is that whenever somebody comes, that there is no need to restart the regimen again. Wherever, if they've taken the first injection, you can give the second injection and the third injection after a period of 5 months. If they've taken the second injection, you can directly give off the third dose. There is no need to restart the series. Another, like I said, there are the basic schedule that we follow is the 0, 1, and 6 months. There is a accelerated dose and a super accelerated dose of hepatitis B. This is basically given for patients who are, if they're planned for an biological, or if they're planned for a transplant. This is something that which we can do so that the immunity is built up much faster. So that the accelerated dose, we give the first dose on day 0, the second dose on 1st month, and the third dose on the 2nd month, and a booster at 12 months. Then we have the super accelerated dose, that is 0, 7, and 21 days. Yeah, so the first dose on day 0, second dose on day 7, and third dose on 21 days, and a booster at 12 months. So this is basically if a patient is planned for a transplant, or if patient is planned to get rituximab or some biologicals or a chemotherapy. If we want them to mount a response before they go for immunosuppression, this is what we usually follow. Another recommendation is for patients who are chronic kidney disease or who undergo dialysis, we give double dose. So that is hepatitis B. Another one is the HPV vaccine. So it is recommended for routine vaccine ages 11 or 12 years. Vaccination can be started at age 9, indicated in both males and females, not only females. And it is basically recommended for everyone through the ages till 26. Vaccination is not routinely recommended for everyone ages 27 to 45, but sometimes patients come and we usually give them. There are basically 3 types of vaccine, that is the 9-valent, the 4-valent, and the bivalent. And the valency is basically what all types of HPV, the serotypes that they cover. All 3 HPV vaccines protect against the HPV type 16 and 18. That is the most commonest cause of HPV cancers. We have the Gardasil 4, which covers the 4 serotypes, and the Gardasil 9, and the Servavac, which is produced by the Serum Institute. The Gardasil 4 is around 4,000 rupees, while the Gardasil 9 is around 9,000 rupees, and the Servavac is around 2,000 rupees, which is in our center. Next is the most, if there is a vaccine which is the most important, I would say it as the influenza vaccine, indicated in all patients, especially above 50 years, chronic diseases like COPD, diabetes, malignancies, and pregnancy. It is the inactivated one is safe in pregnancy. All healthcare providers traveling to endemic region. So there's a quadrivalent inactivated vaccine. That is what is commonly being used in our center. And there is a live nasal influenza vaccine, which we do not have in our country. So the live vaccine is contraindicated in pregnancy and immunocompromised. There is always a confusion when to give the influenza vaccine. If you look at the timings and all, it is basically the northern hemisphere. The typical influenza season is October to April. That is the peak winter season. So they actually would advise to give before that. And in the southern hemisphere, since it is different, they would advise to give March and May before their peak winter season. The WHO makes vaccine strain recommendation twice a yearly. February for the upcoming northern hemisphere and September. So what about India? In India, it is unusual because the seasonality varies by region. In southern states like us, Kerala, Tamil Nadu, our peak is during the monsoon. So the southern hemisphere vaccines generally we would like to give it before, that is April, May, and June and all, before the monsoon comes. While to North India, that is before their winter, that is September to October is the ideal time to give. So, but generally we do not follow if they come, and if it is, if they come at any point of time, we give it off. But this is the ideal timing for the vaccination according to the season. Next is the mumps, measles, rubella. So it is indicated when there is we have lots of students and all who come to us who would like to travel abroad. For them, they would always want to check the titer. So we send the mumps, measles, and rubella IgG, and if they do not have immunity against it, we give off the vaccine. It is indicated in HIV with a CD4 more than 100, international travelers, healthcare workers, and outbreak situation. One important thing is that it is a live vaccine. So we do not give it in pregnancy, severe immunodeficiency, and HIV patients with CD4 less than 200. It's a 2-dose vaccine which is taken 1 month apart. And adults vaccinated only with an MR may not be protected against mumps. So MMR we will have to give off the vaccine. So like I said, the most common live vaccine that we in clinical practice that we give is the chickenpox and the MMR. Since it is a live vaccine, it is given as a subcutaneous route. Now, the second most or the most important vaccination that we have along with influenza is pneumococcal. Why? All individuals above the age of 50 are indicated. 19 to 50 with a predisposing medical condition like alcohol use, chronic heart disease, chronic lung disease, chronic heart disease, diabetes, sickle cell disease, anybody with increased risk of meningitis, HIV, Hodgkin's lymphoma, all these are indications for patients with to get a pneumococcal vaccination. Now, if you look at the global burden, community-acquired pneumonia, pneumococci plays a huge role. And the crude fatality rate and mortality goes up to 40% for invasive pneumococcal disease. Hospitalization, mortality rate, it's big. Even the Indian data also suggests that it causes around 55% of cap in India is secondary to pneumococcal. So that is giving you the sheer burden of the disease in our country with a fatality rate of 14 to 30%. And another thing is that depending on comorbidity, also the disease burden is actually high. If you look at this, the most commonest group in which pneumococci infection comes is chronic lung disease, followed by chronic renal failure, patients with asthma, then neuromuscular disorders, immunosuppressive drugs, etc. Previously, you would have all known there was a PCV 13, there was a PCV 23. You would have to give a PCV 13 first, then followed by a period of at least a year or an immunocompromised 8 months. Then you give the PCV 23. Then you give it every 5 years. So it was the schedule was messy and complicated. So then what happened? The need for an expanded protection had to be there. The complex dosing was actually a big issue. So we needed something which was durable, something like a single dose, and which had which protected against the PPSV 23, which short-lived immunity. So thus came the PCV 20. So this has hardly been around 6 months to 1 year since it's been introduced in India. So why is this important is because it has got a wider coverage. It covers most of the the serotypes which cause most of the invasive pneumococcal disease. And the major important thing is it is a single dose vaccine. So you give a single dose for life and that's it. It ends with that. There is no giving a 13, there's no giving a 23, no revaccination after 5 years. So it is just a single dose of pneumococcal 20. Built on a conjugate platform, it produces strong immune memory and provides long-lasting protection. So this is the PCV20, and basically it takes care of all the major serotypes causing diseases of invasive pneumococcal disease. So the vaccination schedule, anybody above the age of 50 years is indicated for pneumococcal disease. Anybody in the age group of 19 to 50 with a comorbidity is indicated to get PCV20. Now we will come across patients who've already received either a PCV13 in the past or a PCV23 in the past. So if they've received a PCV13 in the past, after 1 year, you can give off the PCV20 and finish off with that. There is no, again, a pneumococcal vaccination required. If they've received only a PCV23 previously, after 1 year, you give off the PCV20 and it finish it off. Some patient, they would have already received the PCV13 followed by a PCV23 and they've been taking it every 5 years. So after 5 years, when they come for the next vaccination, give off the PCV20 and we end the pneumococcal vaccination with that. So like I said, the PCV13, PCV23 are now outgone, and this is the PCV20 which we have. The rate comes around 5,500 in our center. Next is the meningococcal vaccine. We have a lot of students who are planning to go to the US, Germany for higher study. They actually require meningococcal. Even in our, when there is overcrowding and all, there is a high chance of meningococcal outbreaks. So it is indicated during outbreaks, inter-epidemic periods, for travelers, pilgrims, etc. is your Hajj. Whenever they go for Hajj, meningococcal vaccine is a must. Adults with asplenia or functional asplenia, mass vaccination. What we give in our center is the quadrivalent meningococcal vaccine, Menactra. That also comes around 2,000 rupees. It's a single dose vaccine. And the polio IPV, we do not have it at our center, but it is being given in patients who are planning to travel to areas where polio is still present, like Afghanistan and Nigeria and all. Oral polio is generally not indicated in adult, and another thing is oral polio is live also. So that has to be considered before we give the vaccine. Then we also have the RSV vaccine, which is going to, it is already starting and it is going to be launched in India. The main thing is to be given in pregnancy from 32 to 36 weeks and gestation from September through January. It is actually in the vaccination schedule in the US. Another important thing is boostrix, that is diphtheria, pertussis, and tetanus. So unvaccinated or vaccinated after 11 years of age, in pregnancy and in wound management. So one dose Tdap, then one dose of TD, or at least 4 weeks later, and after 6 to 12 months, then every 10 yearly. So that is, so we advise boostrix every 10 yearly. Another common question that we come is, you take a tetanus vaccine, then you have a wound, when should we give a booster? So if the wound is a clean minor wound and with the last tetanus shot less than 10 years, there is actually no need for a booster dose. If it is more than 10 years, we actually advise for a booster dose. If it's a dirty or a high risk wound, and if the shot was taken less than 5 years, we do not advise for a booster dose. But if it is more than 5 years, we can advise for a booster dose. And if it is an unknown with an incomplete vaccination, we have to give the vaccine also, possibly tetanus immunoglobulin. Another very important vaccine is yellow fever. We do not have it at our center. The only two places where we can get yellow fever vaccine is, one is in Port Trust and another one they've recently started giving it at the airport also. It is a live vaccine and it is a must vaccine if you're traveling to high risk areas in Africa and South America. The vaccine entry documentation is required to enter into those countries. It's a live vaccine. Again, live vaccines we give subcutaneously. Protection starts from 10th day and lasts lifelong. So if you're planning to go somewhere, the vaccine has to be taken at least 10 days prior. Since it is a live vaccine, it is contraindicated in organ transplantation, malignancies, pregnancy, and allergy to eggs is also a very an issue with a yellow fever vaccine. Another common vaccine that we are using is rabies vaccine. We have the pre-exposure and the post-exposure vaccine. There are small differences in the WHO guideline when you compare it with the Indian guidelines. But what the Indian guidelines suggest is that for pre-exposure, which is basically 3 doses of the rabies vaccine given at 0, 7, 21 or 20. That is pre-exposure. The post-exposure, you've got 2 regimens. That is the intradermal regimen, which is usually given in government hospitals. In our hospital, we give of the IM vaccination. So it is basically a 5 dose, 0, 3, 7, 14 and 28. And a few doubts that we have regarding the rabies vaccine. Pregnancy and lactation are not a contraindication of rabies vaccine. Chloroquine reduces the vaccine response. In HIV and severe immunosuppression, we should always consider giving them the rabies monoclonal antibody or the immunoglobulin with the complete vaccination. Interchange of vaccine is not advisable, but if not available, then we can actually use and no need to restart. It is just to continue and finish off the vaccination schedule. No post-exposure prophylaxis recommended for raw or boiled milk from suspected animals. The vaccine potency is compromised if it is frozen. Another major question is when to take it. If a patient has completed a pre or a post-exposure prophylaxis, then for the next 3 months, even if he has a dog bite, no re-exposure is needed. If it is after 3 months, then they only require 2 doses. That is a 0 and a day 3. If after a bite patient has received the vaccine, the monoclonal antibody or the rabies immunoglobulin can be given even up to the 7th day from receiving the first dose of the vaccine. After 7 days, there is generally no benefit of giving the monoclonal antibody or the immunoglobulin. So as you all know, COVID, I'm not going into it because my understanding is that currently there are no available COVID vaccines in India. So the Indian consensus that the API had come out with a list of vaccinations to be given to all different kinds of risk groups. So healthcare personnel, the main vaccination that we would advise would be the influenza and the pneumococcal. Depending on the area, the typhoid vaccine has to be advised. The Tdap, which has to be given every 10 years. Hepatitis B, MMR and COVID MMR and chickenpox depending upon the host. Similarly, for diabetes mellitus, chronic liver disease, heart disease, it is basically these vaccinations which we have to give. So another major consultation that we get is post-splenectomy vaccination. What all should we give if a patient comes with a splenectomy or a post-splenectomy? The major 4 vaccines that we have to give is the single dose pneumococcal vaccine, the meningococcal vaccine, 2 doses 2 months apart, followed by a booster every 5 years, the yearly influenza, and a single shot of Hib vaccine. Now the ideal time for vaccination, if it is an elective splenectomy, we would like to vaccinate the patient 14 days prior to the surgery. If it was an RTN and the patient had to be taken up for an emergency splenectomy, we would like to give the vaccine after 2 weeks post the surgery. Another is list of travel. So whenever a patient comes to us with a history of going to somewhere, we would generally like to look what all diseases are endemic there. If hepatitis A is endemic there. So depending on that, we actually advise what all vaccines to be given. And also the host is also important, whether the patient is immunocompromised, whether the patient is pregnant. So vaccination or the decision to vaccine, there are a lot of factors involved in that. Just as mentioned on the special vaccine, there is the hepatitis E vaccine, not regularly given but available in India. Hepatitis E, the worst mortality usually comes during pregnancy. There is the chikungunya vaccine and the Japanese encephalitis vaccine, which are usually given in that endemic regions. The mpox and the malarial vaccines are in, they have been, they are not available in India, but are being used outside the country and slowly might actually come to India in time. So I'll just go through a few common doubts that usually, us doctors will have. One of the most commonest is how many vaccines can we give? So, sometimes if, we get lots of students who come to us and they will come with a bunch of at least 8, 9 vaccinations, which they have to get before they can go. So there is actually no maximum number of vaccines that can be given at a single visit. If a patient is eligible for multiple vaccines, they can generally be administered on the same day at different injection sites. The ACIP and other bodies specifically state that vaccination should not be delayed simply because several vaccines are due. Another thing is, can we give a live vaccine and kill vaccine together? Also, we can give it together. The only thing is that if we are giving live vaccine, you can either give them all together or generally within a gap of 2 to 4 weeks. Another thing which I've already said, whether to give a vaccine IM or subcutaneously. Generally, all kill vaccines are IM. Subcutaneous vaccines are the live vaccine, and the two main live vaccines that we come across in daily clinical practice is the MMR and the chickenpox vaccine. Now, coming to pregnancy, generally, like we already discussed, we avoid live vaccines. The influenza vaccine, Tdap, and the RSV vaccine are recommended in pregnancy. Another important thing is that they will come and tell that they've got so and so allergy to so and so antibiotics. Generally, antibiotic allergies are not a contraindications to vaccination. Sometimes they might come with egg allergy. If a patient has egg allergy, mumps, measles, influenza, rabies, we might have to reconsider. Yellow fever, especially egg allergy, is a contraindication for yellow fever vaccination. Another consult usually we get is, we get patients from rheumatology, neurology, gastroenterology before starting immunologicals, biologicals like rituximab, infliximab and all. So rituximab is notorious for causing reactivation of hepatitis B. So checking the hepatitis B titers, including the core, checking for latent TB by doing an IGRA, checking for pre-op screening. And for such patients, pneumococcal, influenza, the Shingrix, hepatitis B, Tdap are the non-live vaccines that we generally give. Another question is, we have a lot of patients from hematology and other who are undergoing chemotherapy. So when can we give vaccines in chemotherapy? Inactivated vaccines are generally safe, but the immune response may be reduced. Live vaccines are contraindicated during chemotherapy. So when do you vaccinate? Ideally, 2 weeks prior to starting chemotherapy for inactivated vaccines and 4 weeks prior to chemotherapy for live vaccines. During chemotherapy, we can give influenza, pneumococcal, hepatitis B, and Tdap. Main thing is to avoid live vaccine. Then you've got a certain population who would come and say, I'm taking chemotherapy every week. So then what we do is actually so the idea is that if we give the vaccine, the efficacy of the vaccine will not be great. So that is the main, but having some immunity is always better than no immunity. So if somebody is on a weekly chemo or a twice weekly chemo, we ideally take a time period in between. So if it is between, if the patient is taking bi-weekly chemo, we ask them to come in between that and we give off the vaccine. A special mention about rituximab. Why? Because rituximab depletes B cells, causing marked impaired antibody response and reduced vaccine effectiveness for months. So anybody who's planned for rituximab, vaccinate with influenza, pneumococcal, hepatitis B, Shingrix at least 4 weeks prior to rituximab. Once they give off the rituximab, then it is ideal to wait for 6 months to give off the next set of vaccine, because otherwise the meaningful antibody response might not happen. The only exception is influenza. Vaccinate anyway. Some protection is always better than none. And live vaccine we do not give in rituximab. Then another question is, patient is receiving steroids. So can we give off vaccination? So inactivated vaccines like your influenza, pneumococcal, hepatitis B, Shingrix can be given regardless of the steroid dose. Live doses, that is MMR, chickenpox, it actually depends on the steroid dose. So the CDC defines the high dose steroid as something like prednisolone of a dose more than 20 mg per day for a period of more than 2 weeks. For those patients, we generally do not give live vaccines. We would like them to stop the vaccine, and only after 1 month do we give of live vaccines. And another important group is post-transplant patients. They have a huge schedule in which they have to get yearly influenza, 3 doses of pneumococcal, 3 doses of Tdap, 2 doses of meningococcal, 3 doses of hepatitis B, 2 doses of hepatitis A. And so when they come, we usually chart it out and we actually give them the vaccine card so that they come and take it. The influenza vaccine is given yearly, and live vaccines are usually given 2 years post BMT and off immunosuppression for 12 months. So the main idea is never miss an opportunity to give inactivated vaccines. The challenge in immunocompromised patients is not safety, it is vaccine effectiveness, especially with rituximab. So if there are any take-home messages, it would be that adult vaccination is underutilized in India. The main vaccine, if somebody asks you which are the main vaccines you should give, I would recommend the influenza and pneumococcal. One major concern in our country would be the influenza is around 2,000 rupees, the pneumococcal is around 5,000. So giving those two itself is around 7,000 rupees. And generally, my understanding is that insurances do not cover preventive therapy. So that is a major issue which we will have to, tackle. So influenza, Tdap, hepatitis B, Shingrix, and pneumococcal are the most important adult vaccine, out of which priority should be given to influenza and pneumococcal 20. Always vaccinate before an immunosuppression therapy or procedure is going to be started. Most inactivated vaccines can be co-administered, and every clinical encounter is a vaccine opportunity. So another thing is that only if we are actually, if we believe in this, would we actually advise a patient. So if I ask how many of us have actually taken the flu vaccine, I'm pretty sure not everybody would have taken the vaccine. So only if we are actually, only if we are actually have a belief in this, would we actually explain this to our patients. So this is how the CDC have come out with their vaccine schedule. So basically, it is we look at the age group and we what all vaccines are required. Based on the disease, what all vaccines are required. Then we look at the host and then we actually give off the vaccine. This is the vaccine schedule given by the API, which have actually come out with the Indian consensus guideline on adult immunization. This is freely available in the internet. This had come out around a year and a half ago, and my recommendations have been taken from the Indian guidelines. So I hope all of you have understood. And if there is one takeaway message, it would be to vaccinate for flu and pneumococcal to everybody.
Eva? Veena?
Yes, I'm here. Yes, thank you, Dr. Kiran, for the very enlightening talk in a very simple language. I should congratulate. It was an easy understanding. You all will agree with me that. And your take-home message, the last but one, that is every clinical encounter is a vaccination opportunity. As a senior citizen, I can also personally receive recommended adult vaccination as you suggested. And I can attest that vaccination is not just about preventing diseases. It is about maintaining independence, productivity, and well-being in later life. So I also recommend that all above 50 years should have a minimum 3 immunization, though it is expensive in the later years. We hope that we can. I think the latest update, Dr. Kiran, 2026 also has been released, Indian consensus guidelines. And I should endorse that IMA Bombay West is also part of API in developing this Indian consensus guidelines on adult immunization. And 23 different professional organizations has collaborated with this for bringing out this beautiful guidelines. All should go through this guidelines. Latest 2026 has been just released. I can share in IMA group so that this, and I also request Kiran to just
Yes,
give the
sir.
PowerPoint to Dr. Deba so that all will have the minimum resource, a very good reference, your slide preparation. And over to the audience and the Zoom platform, any doubts or any
Just one
clarifications
more
you
thing that I
need,
wanted to say that
please.
generally everybody has this one, that once you take the vaccine, the disease will not come. So it is our responsibility to make to educate them that taking the vaccine does not mean that the disease will not come. It is to make sure that they do not get hospitalized because of the disease. The disease would come and the clinical manifestation would be minimal, because we've had patients who come and in a complaint method that we came and took the vaccine, still we got the flu. But then I would always tell them that you have not been hospitalized because of the vaccination. So that is also, I think, one thing which we'll have to, whenever we give the vaccine, we'll have to educate them that this is not that it will prevent the disease, but patients can still have the disease, but it would prevent them from an hospitalization or getting bad.
Okay, let me just say a few words, Dina.
Sure, sir.
Yes, sir.
That's a very lucid presentation, crystal clear without any jargon, and it was, I think everyone has appreciated, I'm sure about that. And I would also request you to give permission, or you can send the article for publication in our medical journal, Kerala
Yes,
Medical
sir.
Journal. I think the editor is also probably present here. My point is that, in fact, my branch, that is AMS, I am the state president.
Yes, sir.
Incidentally, my branch, Madhya Kerala, started immunizing adult population and the family members in our branch since 5 years.
Yes, sir.
That is the one thing I started in the branch. Now I have extrapolated to the state level. Most of the branches are doing it, and we are getting vaccines at subsidized rates, discussing with the vaccine manufacturers. In fact, my negotiation with the area at state level is still going on. But at branch level, they are managing it. Discount rate we are getting. And last immunization day, I think our branch, we had nearly 250 people who got the various vaccines, including the HPV, what do you call, varicella, then herpes zoster, the hepatitis, definitely the pneumococcal vaccine and influenza vaccine. We have been taken regularly.
Yes,
that
sir.
is for sure. And we are all happy with that, because we are not getting infections as previously we used to get it. That is a message, and why it is getting popular in our branch. And I am spreading this message all over, because empowering the doctors, healers, and the family members is one of my agenda, through scientific update, through healthy lifestyle, and burnout syndrome avoid. All these things are there, and immunization is so part of that. And I just want to ask you one thing about this dengue, whether we are coming out with any vaccine in the future.
Yes, sir. There is a study. There is a vaccine which is actually going on by the ICMR, sir. It is supposed to come out. The initial studies are still going into. Right now, we do not have a dengue vaccine in India right now, sir. But there are a couple of vaccines which are in the pipeline, which will come actually, sir.
There are more questions in the chat box.
I think one question is there. Should I read?
Please. Please do that.
I have a question. I mean, AAK. I don't know who is that. If a patient gets the titers for mumps, measles, and rubella, and the report comes, mumps and measles are having high titer, and rubella is having low titer, is it recommended to take another MMR vaccine? And should there be a second dose taken after 4 weeks?
we usually get a lot of students who would actually, planning to go to Germany, UK, and US and all. For them, this is actually a criteria. So we get lots of students with, either the immunity to mumps will be there, to rubella will not be there, like what this patient is. So generally, we give off the MMR vaccine. Looking at the host, if the patient is not immunocompromised, if the patient is not pregnant, it is a live vaccine. So we give off the first dose. And generally, because it is for travel purposes, we give off the first dose, but then they usually go and then they don't actually come back. But for travel purposes, it is, I think, because it is just the immunity is only less for that, either the mumps or this one, we can give off one vaccine to them.
Now, HPV is freely available in India as per the central government policies.
Sir. Yes, sir.
So should we?
And doctors, yeah, please.
Carry on.
Dr. Sadish Prabhu has come up with another question saying that what is the how efficacy in terms of how effective is hepatitis B
is already
vaccine?
known to be very effective. That is why all healthcare workers it is a must that all healthcare workers must take hepatitis B. Another thing is that there are a few non-responders. So even after one series of getting 3 doses, when we check the titers, they might not have the titers. For them, we actually repeat the dose, and then still if the titers are low, we actually brand them as true non-responders. For them, we might have to give hepatitis immunoglobulin and all. But generally, hepatitis B is very effective.
Another question, name is not the BioVac A efficacy compared to Havrix.
The BioVac is actually a Chinese vaccine. It is a single dose vaccine and it is a live vaccine. So that is a major issue for usually hepatitis B in our center, which is a large transplant center. We generally do not prefer giving live vaccine. So we stick on to the inactivated Havishor or Havrix. And the Chinese vaccine, compared to the inactivated, the efficacy is said to be on the lower side.
And Dr. Menon has mentioned that HPV is made freely available by
I just mentioned
central government. Yeah. So has it come to the national immunization schedule?
No.
Anyone can answer.
I do not feel it is currently there, ma'am.
Yeah.
It is not currently there, but some campaigns are coming in between in government sector. And that time we can go and immunize the both boys and girls between the ages of 9 and 40.
Yes.
That campaign is there.
Yes, ma'am.
It will come soon, I think. And I think Amrita is also a part of dengue vaccine study as part of ICMR. And the third phase is going on.
Yes, ma'am.
Trial.
We were part of the RSV vaccine as well, ma'am.
Yeah, RSV vaccine also. Because it is now available as I thought I didn't mention that. So I think it was so many 100% score for you, Dr. Karan. Excellent talk. It has been mentioned by many doctors.
One doubt.
One more question is there.
It is regarding varicella. Somebody has varicella in a family. So others come and ask, should I take a vaccination or not? What is your advice?
The ideal guidelines recommend vaccination, sir. That is, the guidelines recommend vaccination. But like I said, we would have to inform them that getting the vaccine does not mean that they will not get the disease.
Yeah,
because they are in that period, they would still get the disease, but the severity of the disease would be less.
Yes. Yeah.
One more question is there in the chat box. Can pneumococcal vaccine be administered to people above 85?
Yes. Now, since we have the pneumococcal 20, it is just a single dose vaccine. So definitely we can give off that single dose and finish off pneumococcal vaccination.
So another is I contracted mumps 4 months back. What is the recommendation for MMA for me?
So
By
see,
Dr.
if the patient,
Shibin.
if he's already contracted mumps, he would definitely have immunity against it. So if at a later stage,
Yeah.
we could actually do the IgG and see if titers are there and then decide. If titers
No,
are there, then there is no need for a
what
revaccine.
about measles and rubella? That is the question.
I know that
We got
again, we would do the titers. If the titers
Okay.
are not there and if it is required, we can give it off, sir.
And again, you have mentioned that even then another question is there, ideally influenza vaccination, southern or northern hemisphere, trivalent or quadrivalent?
The southern or northern
You have
hemisphere
already
is not
mentioned.
ours to choose. It depends on where the patient is actually. Trivalent, quadrivalent is better than the trivalent.
So the usual time when the flu vaccine comes here, what is the time?
So that is what I said. Generally, before the monsoons is what we would actually say in Kerala.
Yes.
That would be somewhere
That's why
like March to
we just
April.
had it last month.
Yes,
We had
yes,
it last
yes.
month.
This year's vaccine has just
Then-
been recently, it has come out.
Well, almost all the
Sorry, yeah.
vaccine is a trivalent now.
Yes,
Latest
sir.
one.
Yes, sir.
Trivalent. They are telling that the other strain is not seen since 10 years.
But we are having quadrivalent, no?
Yes, sir. Yes, ma'am. We have it now.
Only one company is.
And every month.
Others are trivalent.
Yes, sir.
Vaccine grippe,
Yeah.
vaccine flu, every other trivalent.
Yes, sir.
Only fluarix tetra is only quadrivalent.
Yes, sir.
So hope now is the exact time for influenza vaccination.
Exactly, sir. I took my shot around, I think, 3 weeks back.
I
should
had,
This is the time you can still
almost,
take. Dr. Abraham, you can still take.
we have taken it almost 2 weeks back.
We are planning to give in Payyanur IMA.
Very good, sir.
Yeah.
Trivalent we are giving.
I think IMA should take the lead, I should say.
Yeah, I
Menon,
have
sir,
taken the lead. I have instructed everyone to have
adult vaccination.
I have been campaigning it for information. That is why this talk has come up. This talk is also my request to Jiva.
Yeah, this topic was
Very
requested by
good
Sir.
topic.
I think
So
Angamali
it
branch
was
has
very
announced
useful,
the
Deepa.
campaign for adult immunization at for influenza
Every
vaccine.
branch should take up. That is what I'm saying. And all those present here above the age of 50 and 65 with comorbidities and all, they should get vaccinated, no doubt.
We will get for 600 to 700 rupees for this flu vaccine now for doctors.
What about pneumococcal?
We had it for 850. That is why I
5,000.
said you can bargain and get it done.
They will give 1,000 rupees. It will be less. 555. It will get 4,555. Pneumococcal. This flu vaccine he will get for 700.
Anyway, not covered by insurance.
No.
No, not covered. But some banks they are giving this.
Arda sir, you are from Payyanur. Yeah, I will call you later.
Thank you, Dr. Kiran, for this wonderful session once again. And I request all the members who are now on the Zoom platform, let us live in a routine part of our clinical practice and standard of care. That commitment you should take, and we will move forward with adult vaccination as successful as pediatric immunization. Thank you, and over to Dr. Deepa.
Thank
ma'am.
Thank you, Dr. Beena, for sharing that session in a wonderful way, and Dr. Kiran for that excellent but crisp and presentation. And as Dr. Beena said, we should be committed towards adult vaccination, and we should propagate adult vaccination in almost all the IMA branches, and all the doctors also should take vaccination as and when needed. So let me invite Dr. Vinod for the vote of thanks.
Thank you, ma'am. It was a wonderful session led by Dr. Kiran. First of all, let me thank Dr. Kiran for presenting such a detailed presentation on this very relevant topic. And I thank IMA Kerala State President Dr. M.N. Menon sir for being the guiding force, and Dr. State Secretary was there for a few minutes. Sometime earlier, Dr. Roy was there. Special thanks to him, and thank you, Dr. Deepa Augustine, and all the Dr. Beena for moderating the session, and all the senior leaders and dear friends who attended the session to make it a successful discourse on this topic. Thank you. Thanks a lot.
Thank you.
I would like to thank the IT coordinator also, Krishnan, because without his help, we won't be able to
Yeah, absolutely.
have the Zoom
Absolutely. Krishnan was
platform.
very prompt and very helpful. Thank you. Thank you,
And this
Kiran.
was Menon sir's suggestion to have the topic on adult immunization. Okay. Thank you all once again. Thank you, Menon sir. Thank you, Dr. Vinod. Thank you, Dr. Beena, and thank you, Dr. Kiran. Thank you, all the participants, and have a good night. Thank you.
Thank you.
Good night. Good night.
Good night.